treatment. Now we'll speak about angiogenesis inhibitors. And in the near future, they sounded like exotic treatments, but not anymore. So these angiogenesis inhibitors, they are now very actively used in our practice, and actually there is no alternative to this treatment. Speaking about application points for these treatments, this is diabetic retinopathy, NAMD, and DR. And there is a program where we can look at the positions of the patients and medical specialists, the tendencies and practical approaches that are offered to provide medical care in case of neovascular form of AMD and diabetic retinopathy. Globally, the growth of patients with this pathology is stunning. Here on the slide, you see estimations, and definitely it's very rough estimation, but still it's stunning. So with that fantastic growth of a number of expected patients, definitely the topic of using anti-VEGF treatments is becoming more and more relevant, especially keeping in mind comorbidities. About 50% of patients with AMD had involvement of the contralateral eye within the next 5 years. And you see these rankings due to different publications. Yes, there are some fluctuations, but still figures are very impressive. So diabetic macular edema. So the average time of involvement of the contralateral eye, 6 months in both eyes involvement. We see dramatic reduced quality of life by 22% at least. Very serious. The fact that anti-VEGF treatment is a treatment for long-term perspective, it creates a big burden for the healthcare system, burden for the patient himself or herself, and also to the relatives. Frequent injections. Patients don't want to become a burden, so they want to have more time even to answer the questions, even logistical issues sometimes, and for our country it is quite relevant as well. And here, the position of the patient and position of a doctor are quite comparable. And this is data shown by Levenstein and the colleagues, and it is quite applicable to our current reality. So what are molecular properties of the drugs could play a role here in the clinical effects? Here we can appreciate the line of products we know very well: brolucizumab, faricimab, ranibizumab, and aflibercept. When we discuss these molecular properties, when we start analyzing them, when we look at the affinity to treatment and half-life time, half-life period of time, so we understand why aflibercept appears to be the priority here, because actually the target for aflibercept is much more diverse. So options with anti-VEGF activity, they are established to minimize the burden from treatment, because increased intervals and dramatic increase of intervals, this is an important story, again in the context of comorbidities we just were speaking about. And over here you can appreciate that aflibercept has a very interesting profile. So this is intensive treatment with intervals less than 8 weeks in patients with high activity of the disease. It could be possible increased interval for the patients with lower activity of the disease. So very flexible schedule. So some of the patients definitely need intensive treatment. That is why what could be changed in this situation if the aflibercept that we know very well, that already gained our trust, if it's a high dose of aflibercept. So, and this is Eylea. very well-known treatment in the dose of 8 milligram demonstrated the option to increase the interval up to 6 months. That's very interesting. That's very interesting data. That's exactly the highest bar possible that we would like to take over. So 8 out of 10 patients with ALIA 8 milligram had interval between the injections from 4 months to 6 months to the end of the second year. So very balanced burden, and this is data of PULSAR study. Only 1 out of 10 patients needed injections with interval of 8 weeks by the end of the study. So the drug with such characteristic ALIA 8 milligrams effectively blocks VEGF factor up to 119 days versus aflibercept in the dose of 2 milligram. This is how here on the slide you can clearly visualize the dramatic improvements that ALIA gives us with a new dosing, and we enjoy new options. Increasing the dose, so this is up to 9 additional weeks of VEGF blocking using ALIA 8 milligram versus aflibercept if it is used in the dose mentioned here. So the design of the study of PULSAR and PHOTON. So in PULSAR study, by the way, the task was non-inferior results with aflibercept 2 milligram, minimize the number of injections, and PHOTON, this is use of aflibercept 2 milligram fixed comparison with 2 groups of the patients with aflibercept. So definitely we are not diving deep into each study, but the design and actually initial positions are very clearly shown. ALIA in the dose of 8 milligram demonstrated the option to increase interval between the injections up to 6 months, 4 to 6 months, and the majority of patients with NAMD and diabetic macular edema. So you see these are scheduled injections intervals and the patients, how they are randomized between the groups. So in PULSAR it's 78%, in PHOTON it's 89%. And this sounds interesting and quite convincing. It proves what I said before. Now, the visual acuity and the thickness of the central retina. It is very important, and this slide shows us that although the injections are now very rare, but the patients with NAMD in the treatment of ALIA 8 milligrams managed to support visual acuity they reached and the thickness of the central retina. That is shown here on the slide, and definitely the graphs go in different ways, but in fact they are reflecting different parameters. So this is PULSAR study, but again, this very steady position of the curve we see here, this is exactly the confirmations of the statements were presented before. Now, PHOTON study, ALIA in the dose of 8 milligram provides meaningful visual improvements in patients with diabetic macular edema, regardless of the status of previous treatment, which is very important because the issues of earlier treatment or switch, they're always concerning because the desire to get effective treatment is seen always because actually it is in our medical function. So the average change of the minimal corrected of BCVA through week 96 in the prior treated and prior not treated patients is shown here. You can see mean changes of best corrected visual acuity in the number of charts in the table. This is fluid control, which is important morphological confirmations, because actually visual acuity is very important factor, and almost always it's quite subjective, but very objective control here. This is sustainable fluid control in patients with DME, regardless of the previous treatment using ALIA 8 milligram. So it's clearly shown on the slide, and we follow it up during follow-up period of 96 weeks. 96 weeks. Just think it over. So this is really very long data, very convincing data. So using this dosage, we do hope to have this control of the morphological condition of the retina. Well, these accumulations, they're very valuable, but it should not be just the generalizations between because clinical examples, they're very important because we can feel that the initial data and the results that were obtained through some follow-up period, keeping in mind age, gender, group of treatment. So all that, I believe, is the second side of the medal. So this is the second part. And now doctor is absolutely convinced that truly the drug in the proper dose could support such fantastic functional and morphological effect. Week 24, interval 4 months. Here you can appreciate the changes that macular area is demonstrating as a result of injection. So this is very convincing, and it is showing us on this example. This is week 40, and you can appreciate the data. Week 56, week 76 at the end. This is interval of 6 months. So we can appreciate here that 60-year-old patient here, the parameters, so the functional visual acuity and morphological visual acuity looks very convincing. So that's exactly the effect we expected. So, and in fact, it is reached. Now, a very sustainable resorption of pathological fluid and 6-week interval in area 8 milligrams. So this is loading of injections and the second year. So initially here, you can see that maximum and best visual acuity, best corrected visual acuity, and the thickness is 419. So this is the next picture. So this is week 96. So this is increased visual acuity and very convincing reduction of the thickness of the central retina. When we speak about comorbidities, it is very clear that we are quite concerned about it. And one of the questions in intravitreal injections in the context of the issues that we are discussing now, this is definitely increase of intraocular pressure, IOP. So we have to mention here, if it's acute increase right after the injection, so that is the topic which was already considered many times, and the episodes of the acute peaks, they are normally self-resolved and they do not require any special treatment. And the changes of IOP could depend on the volume of the drug, the diameter, the pace of introduction, the properties, and in fact, in the vitreous body itself. For intravitreal injections in routine practice, normally this volume is no more than 0.1 milliliter, which meets expert guidelines. So the total volume is considered as 4.4 milliliters. So that means with this short volume, this short-term increase is absolutely safe from the point of biomechanics. So it should not give any critical data. And in the context of patients' comorbidity, so there is no risk in this short-term increase of IOP. So intraocular pressure, coming back to the baseline in 30 minutes in majority of the patients, the maximum elevation of IOP after intravitreal injection should be resolved within first 10 to 15 minutes. And this is time after the injection. So this is publication of Stefan and co-authors. You see the IOP and the peak data, and you see that it returns to the baseline values within 13 minutes, and you see the maximum increase in IOP after intravitreal injection occurs during the first 10 minutes and then resolved. If we deal with the situation when intraocular pressure is increased before the injection, then quite possibly it may require some paracentesis, and this is one logical. So this is how we can minimize the volume of the anterior chamber due to paracentesis. And if paracentesis is performed, then 30 minutes after the intravitreal injection, the intraocular pressure remained above 35 millimeters of mercury. So if IOP is increased, and this is data of Korobelnik, who is a famous French study. So this is clinic that is specializing in it with many publications. So here you see cases of elevated IOP accounted for less than 1% in all of aflibercept groups. So this is how aflibercept 8 milligram gives us very good safety profile, and you see that baseline data and week 48 data were absolutely the same. So this is open data, and it is frequently quoted as Bayer study, which is Pulsar. We don't see here any increase in IOP before the next injection among the therapy groups at all stages of the study. So this is Pulsar data, and this is IOP data. So this is safe volume of IOP, and they can reach 0.2 milliliters. So less than 1.1, definitely here we can hardly get any effective administration. So this is American Academy, which is recommended frequently introduce 0.5 milliliters and the maximum volume without a preliminary paracentesis is also limited with 0.1, 0.2 milliliters. In the context of comorbidities and problems that we are discussing now, so these are risks of systemic adverse events. We just enjoyed a fantastic presentation about mitochondrial effects. So this is already a systemic effect of the drug, which was focused on specific tasks. And also here using the anti-VEGF, so we're thinking about one, but at the same time, this is universal effect. This is anti-VEGF treatment. Do you think how risky it could be in the general regulation? And the risk of systemic adverse events, are they really serious? Because we have serious predispositions to that. But in the clinical trials, in intravitreal administration, anti-VEGF drugs had a very safe profile, systemic profile. There is systemic meta-analysis, which was published a few years ago, and anti-VEGF treatment never increased the risks of cardiovascular events and never influenced all-cause mortality versus control group. In the meta-analysis, from the point of analysis, that's very strong publication. So, and this is where we study its in targeted way, and the rate of cerebrovascular and thromboembolic events with anti-VEGF less than 0.1, 0.7%. And it is clear that control, it is not related to anti-VEGF activity. So, non-ophthalmic adverse events of aflibercept 8 milligram was absolutely compared with aflibercept of 2 milligrams. So that means similar safety profile. So 8 milligram versus 2 milligram has the same very favorable safety profile. Earlier, the dose of 8 milligram demonstrated a very favorable safety profile in relation to systemic adverse events, which are myocardial infarction, cerebrovascular accidents, cardiac arrests, acute coronary syndrome, cerebral infarction, and death. So, increased concentrations have very favorable safety profile of cardiovascular safety. It was shown in Pulsar study.
Очень важно подчеркнуть, что современные ингибиторы ангиогенеза в лечении коморбидной патологии должны
So in the treatment of comorbidity, it also should be safe and effective. Looks very acute and provides optimal therapeutic effect in minimal number of injections. So I hope the data I showed how important this position is. Minimal number of injections. This is reduction of the burden to the patient, to the system, and aflibercept in the dose of 8 milligram actually meets these needs. So very prolonged and effective drying of the retina. Yes, this slang is also used in the English-based literature, but this is what we are trying to reach. So we have to remove this excessive fluid in order to increase visual acuity. And the data I'm showing here, more than convincing to use this drug more frequently in your clinical practice. And thank you very much for your attention.